Hi, good morning, doctors. Today is the third day for reading Oxford Handbook of General Practice for MRCGP International EKT exam. So I'm your study buddy. I'll be studying with you and make it easy for you to study these textbooks. So we're in page number 195 today. So let's start. Guidelines for prescribing for the elderly. Think before prescribing. Is drug needed? Is there any other non-pharmacological way of managing the problem? Are you treating the underlying condition or the symptoms of it? What are the topics, pros and cons of the patient taking this drug? What is the evidence base for its use in this age group? Will the patient be able to take the drug, formulation or packaging? Will the patient be concordant? Will the patient comply with any necessary monitoring? Limit the range of drugs you use. Prescribe for a limited array of drugs that you know well. Repeats and disposals. Tell patients how to get more tablets and monitor frequently for repeat prescriptions. Review repeat prescriptions regularly. Page number 118. Tell the patients what to do if any leftovers of a drug uh, is stopped. The dose. Decrease the dose. Start with 50% of the adult dose. Avoid drugs likely to cause problems like hypnotics. Review regularly. Consider on each occasion whether each drug should be stopped or the regimen simplified. Consider lowering the dosage of the drug if renal function is deteriorating. Involve carers, community pharmacists, and other PHC team members in this. Simplify the regimens. Use a OD or BD regimens wherever possible. Avoid polypharmacy. Explain clearly. Decision aids can be helpful. Put precise instructions on the drug bottle. Avoid use as directed. Give written instructions about the drug, how it should be taken. Ensure explanations are given to the carers as well, if appropriate. Consider method of administration. Bottles with child-proof tops are often impossible for the arthritic hands to open. Suggest the patient asks the chemist for a standard screw cap. Drug administration boxes in which the correct tablets are stored in the slots marked with the day and time of administration can be helpful. Available from the pharmacist and can be filled by the patient, a carer, or a friend, or a relative, or the pharmacist. Medication reminder charts can also be of help. Elderly care and disability management. Use strengthens, disuse debilitates. That was by Hippocrates. 13 to 14% of the population has some disability. This is increase as populations age and people survive longer with disability. Many more are just elderly and frail, and 35% of people aged more than 80 years cannot live an independent life. Most patients are best managed by a MDT in their home environment if practicable with the problems oriented approach. Good interdisciplinary communication and coordination is essential, and many patients benefit from specialist rehabilitation services. Psychological and socio-cultural aspects are as important as medical aspects of care. Role of a GP within the MDT is a multidisciplinary team. Maintain an open door policy and encourage the patients and carers to seek help for problems early. Try to become familiar with the patient diseases, even if rare. Information alone can improve the outcome. Consider, can physical symptoms be improved? Can psychosocial symptoms be improved, including self esteem? Can functioning within the home be improved? Aids and adaptations within the home, extra help. Can functioning in the community be improved? Mobility outside the home, work, and social activities. Can the patient's or the carer's financial state be improved? Does the carer need more support? If progress is slower than expected or stalls, consider medical problems like anemia, hypothyroidism, or dementia, a neurological event or depression or communication problems. Example, poor vision or hearing aid. Principle of care. Use of assessments or measures. Central to the management of disability, use validated measures accepted by all team members. Example, Barthel Index or PHQ-9 score. Reassess regularly. Multidisciplinary teamwork. Good outcomes are associated with clinicians and other involved in health and social care professionals working as a team towards a common goal with patients and their families or carers, including as team members. Goal setting. Goals must be meaningful and challenging, but achievable. Use short term and long term goals. Involve the patient or carers. Regularly renew, review, or adapt. Underlying approach to therapy. All approaches focus on modification of impairment and improvement in function in everyday activities. May may include drugs, physical, psychological therapies plus social support. Referral for specialist support. Consider specialist medical or rehabilitation services, social services if not already a part of MDT, voluntary organizations, and self help groups. Citizens' advice. Maintaining independence. Common neurological rehabilitation problems. Learning disability health checks. People with learning disability have poorer physical, mental health and die younger. Annual health checks can be offered as directed enhanced service to patients aged more than 14 years on the Practice Learning Disability Register. The standard templates are available within the practice software systems. Health checks aim to ensure all available health prevention measures are offered, example screening, routine vaccinations, contraception, identify health conditions that might otherwise go undetected, optimize management of ongoing conditions, and identify patients or carers who may need more support. Adult safeguarding means to protect a person's right to live in safety, free from abuse, harm, and neglect. Includes proactive and reactive measures and recognizes that adults may choose to make unwise decisions. An adult risk is a person at risk is a person who is more than 18 years and risk of abuse, harm, or neglect because their needs for care and support. Types of abuse: physical abuse, hitting, misuse of medication or restraint; sexual abuse, rape, sexual acts to which the adult has not consented; psychological abuse, threats of harm or abandonment, humiliation and blaming; financial theft, exploitation, fraud; neglect, ignoring health or care needs, inadequate nutrition. 6 safeguard principles underpin adult safeguarding: empowerment, proportionality, partnership, prevention, protection, accountability. The role of a GP. The GP must undergo regular adult safeguarding training. This is assessed as a part of the annual appraisal. They must be able to recognize potential signs of abuse, work as a part of the MDT, including local adult safeguarding services, to take all necessary action to safeguard their patients, reflect on safeguarding events, and take any necessary actions to improve the adult safeguarding within their own organizations. Deprivation of liberty safeguards, DOLS. This we will read in page number 1106. So wherever we are having these page numbers, we will read the topic in the appropriate page number whenever we are encountering it. Elder abuse, domestic violence, modern slavery, female genital mutilation, prevent strategy. Organizational abuse usually affects people in residential care settings, example hospitals and care homes, but can occur in relation to paid care in people's own homes. Individual wishes and needs are sacrificed for the smooth running of the service or organization. Example, there is no choice of food. There is shared clothing, forced early bedtimes. If you suspect, raise with the service provider in the first instance with the patient's or carer's permission if possible. If no action is taken, refer to local social services adult safeguarding lead. So further information, RCGP Safeguarding Adults at Risk of Harm Toolkit is available in the RCGP website. Maintaining independence. Maintaining independence is important. It gives individuals autonomy, a sense of purpose and achievement, and allows them to make their own choices. Lack of independence can result in a feeling of being a burden, boredom, frustration, loneliness, and social isolation. Equipment and adaptations. If difficulty in coping at home due to disability or age, anyone can request a need assessment by the occupational therapist via the local social service department. This enables provision of equipment or adaptations necessary to maintain independence. Benefits: help to use the telephone, Many people have difficulty use the telephone either because of physical impairments or communication problems. British Telecom can provide suggestions about how to address many of these issues. Alarm systems enable anyone who is alone at times to call for help even when they cannot reach a telephone, suitable for anyone capable of using an alarm system, arranged via local social services or housing departments. Alternately, charities for the elderly have some schemes. Age UK personal alarm. Walking aids, wide variety, from simple walking sticks to crutches to range of wheeled or unwheeled walking frames. Physiotherapists can advise on the best mobility aid for each individual patient, can be obtained on loan from the NHS or purchased by the individual. Wheelchairs, if in need, if needed short term, available on loan from local Red Cross branches, the NHS can provide a wheelchair for anyone requiring for one for more than 3 months. Referral must be made by an authorized healthcare practitioner or a GP to the local NHS wheelchair service. After the assessment, individuals can opt for to have an NHS wheelchair or be provided with a voucher towards the cost of their own. Directory of NHS wheelchair service centers is available online. Community transport services available for many areas of people who have difficulty using public transport include door-to-door transport to attend appointments, trips to shopping centers and other outings. Local arrangements vary. Free bus passes may be restrictions on time of travel. Disabled people are entitled to free bus passes in England through the English National Concessionary Travel Scheme if they meet the eligibility criteria, which is there in the box number 8.1. So, similar schemes operate in Scotland, Wales, and Northern Ireland. A carer may also be issued with a free pass if the individual cannot travel alone. Applications are made via local authorities, but the bus pass can be used anywhere within the country it was issued. A GP letter to confirm eligibility may be required. Elderly people. Elderly people can also apply for a free bus passes from 60 years in London, also valid for underground bus passes, and Scotland, Northern Ireland, Wales, and from women's state retirement age elsewhere in England. So there are these free bus passes and concessions for disability. Disability and driving. Okay. So this is box number 8.1. This is the criteria for application for a free bus pass in England. A disabled person is likely to get concessionary bus pass if he or she is blind or partially sighted, is deaf or unable to speak, is unable to walk for very far because of disability, illness or injury, is unable to use his or her arms or does not have arms, he has severe learning disability, has been refused a driving license for health reason but not because of problems with drugs or alcohol. Okay, so whenever we read about the DVLA and restriction from driving, so a they fit to the criteria for application for a free bus pass. When they are not allowed to drive their own vehicles, they can apply for a free bus pass, and the GP may have to give a certificate for that. Is either blind or partially sighted, deaf. So blind, deaf, unable to walk, unable to use his hands, learning disability, refused a driving license. They are eligible for free bus pass in England. Blue badge scheme entitles the holder to park in specified disabled spaces, free of charge or time limit at parking meters or other public places where the waiting is limited, or single yellow lines for up to 3 hours, no time limit in Scotland. So this is a blue badge scheme. The disabled person does not have to be the driver, but the badge should not be used if the disabled person is not in the car. Applications are made by the local authority, automatically eligible if more than 2 years old and one of the following criteria apply. Like, it is automatic if you are more than 2 years old and registered as blind, receiving higher rate mobility component of DLA, or receiving PIP scored more than 8 points in the moving around area of the PIP assessment, getting VAR pensioners mobility supplement, or receiving a lump sum payment as a part of Armed Forces Compensation Scheme, tariffs 1 to 8, and certified as having a permanent or substantial disability. Either you're blind or receiving some schemes, or you have a permanent or substantial disability and you're more than 2 years of age, then you will be able to use this blue badge program scheme. People with permanent problems walking or who cannot use their arms may be eligible and should apply. Each application is judged on its merits. Motability. Okay, qualifying benefits. Must have more than 12 months award length remaining. More than 12 months award length remaining. High rate of mobility component of DLA. Enhanced rate mobility component of PIP. War pensioners mobility supplement or armed forces independent payment. Mobility payments associated with state benefits can be used to lease a car, wheelchair accessible vehicle, scooter or powered wheelchair. Includes many special adaptations, insurance, breakdown, assistance, servicing and maintenance. Grants may also be available for additional adaptations or driving lessons. The driver does not have to be the claimant. Okay. Road tax exemption should be received automatically by anyone receiving any of the eligibility benefits listed in the Motability scheme. So, again we are here, carers. Who is a carer? A carer is someone who is any age who provides unpaid support to the family or friends who could not manage without this help. This could be caring for a relative, partner, friend who is ill, frail, disabled, or has a mental health or a substance misuse problem. Anyone can become a carer. Near about 2 million people per year move in or out of caring roles. Young carers, children and young people who assume inappropriate responsibilities to look after someone who has an illness or disability, is affected by mental ill health or substance misuse. Young carers often take up practical or emotional caring responsibilities that would normally be expected of an adult. Some carers do not regard themselves as carers or may dislike the label carer, believing that it can detract from their identity as a parent, child, partner or sibling to the person they care for. It is also important not to confuse carers with paid care workers. How many carers are there? 12% of adults in the UK are carers. 1.2 million people provide care for more than 50 hours per week. Those aged more than 65 years account for 1 in 3 of those providing more than 50 hours of care a week and may have their own health problems too. There are also around 1 million young carers. Carers as partners in care. Carers know that people they care for better than anyone. Involving carers is important in order to identify problems that may require intervention, plan patient care, and improve concordance with care plans. What problems do carers have as a result of their roles? Many carers gain great personal satisfaction from their caring role and want to continue caring, but they suffer adverse consequences too. Psychological, increased stress and depression or anxiety abuse from the person being cared for. Young carers have increased risk of bullying or self-harm. Physical health is increased mortality, morbidity from CBD and increased risk of back and other musculoskeletal injury. Social activity restriction, deterioration of relationship with other family members and social isolation. Employment, schooling, decreased ability to work, decreased promotion prospects, poor performance and increased absenteeism at school. Financial, the more care provided, the more likely the carer is to be in financial difficulty. 55% are in debt, but less than 50% claim all the benefits they are eligible for. Supporting carers in general practice. Benefits for sickness, disability carers is mentioned, low income. Social services assessment. Every carer has a right to ask for full assessment of their needs by social services. Emergency planning to provide substitute care in the event of a crisis is a part of that assessment. So this is a flow chart. Step 1. Identify a carer's lead. Step 2. Finding and recognizing adult and young carers. Ask carers to self-identify. Ask patients to identify their carers. Opportunistically identify carers in the surgery, on hospital admission or discharge, on letters from specialists, and through the annual flu vaccination program. Search for carers on the practice list. Record carer status on patient notes. Step 3. Involving carers in patient care. Ask permission to share patient information with carers. Involve carers in care planning and care implementation. Provide or signpost carers to training to help them to perform their caring roles. Step 4. Improving healthcare for carers. Consider screening carers at least annually for depression. Provide flexible appointments for carers. Invite carers for annual flu vaccinations. Consider providing other services for carers like annual health checks, in practice specialist carer support worker sessions. Step 5. Providing information and support. Develop links with local carer organizations. Encourage carers to apply for benefits they are eligible for. Signpost carers to other sources of information and support. Refer carers for social services or carer assessment. Ensure carers have an emergency plan in place. Providing support to young carers. Include young carers in step 1 to 5 questions. Question why the young person is taking a caring role. Does the person care for need referral for a review of care needs? Provide age specific information and support. Develop links with local young carers. Leads. Consider referring young carer to local children's services assessment. Step 7. Auditing and improving carer support. Practice action plan for supporting carers. So next, we are in the next chapter, cardiology and vascular disease, 203. Cardiology and vascular disease. Symptoms and signs of CVD. Chest pain, breathlessness and dyspnea, blood pressure, crackles in the chest, peripheral edema, swelling in the ankles or legs, or if sacrum if bedbound occurs when rate of capillary filtration is more than rate of drainage. Increased capillary filtration occurs due to increased venous pressure, hypoalbuminemia, or local inflammation. Decreased drainage occurs due to lymphatic obstruction. So consider whether the swelling is acute or chronic, symmetrical or asymmetrical, localized or generalized. Ask about associated symptoms, example breathlessness. Treat according to the causes. So acute swelling due to DVT, superficial thrombophlebitis, joint effusion hemarthrosis, arthritis, cellulitis, hematoma, Baker's cyst, fracture, acute arterial ischemia or dermatitis. Chronic gravitational edema due to immobility, commonly in elderly. Advise elevation of feet above the waist level. Support stockings. Ideally apply stockings before getting out of bed. Avoid standing still. Diuretics are not a long-term solution. Heart failure, hypoproteinemia, nephrotic syndrome, idiopathic edema, reflex sympathetic dystrophy, post-thrombotic syndrome, chronic venous insufficiency or venous obstruction, lipodermatosclerosis, lymphedema, infection, tumor, trauma, congenital vascular anomalies. Causes of pulmonary edema. Accumulation of fluid in the pulmonary tissues and air spaces is pulmonary edema. Causes are cardiac causes of pulmonary edema. There is left heart failure. There is mitral stenosis. There is MI, hypertension, pulmonary venous obstruction, IV fluid overload. Others, high altitude pulmonary edema, kidney failure, nephrotic syndrome, cirrhosis, lymphatic obstruction due to tumor. Lung causes of pulmonary edema. Pneumonia. Pneumonitis due to inhalation of toxic substances, example gases and radiation, and pulmonary embolism. Cyanosis. Dusky blue skin. Central cyanosis. Cyanosis of the mucous membranes, example the mouth. Causes. Causes of central cyanosis are lung diseases resulting in inadequate oxygen transfer like COPD, pulmonary embolism, pleural effusion, severe chest infection. Shunting from pulmonary to systemic circulation like in phallocytology, PDA, Transposition of great arteries. Inadequate oxygen uptake like MEAT or self-hemoglobinemia. Peripheral cyanosis. Example, cyanosis of the fingers. Causes as for central cyanosis. All the central cyanosis cause peripheral cyanosis. Plus physiological, cold or hypovolemia. Local arterial disease like Raynaud's syndrome. Feet can be dusky blue color due to venous disease. If this occurs without central cyanosis, it does not imply abnormal oxygen saturation. Mitral phases. Dusky bluish red flushing of the cheeks. A form of peripheral cyanosis associated with low cardiac output. Clubbing. Loss of angle between nail fold and the plate. A bulbous fingertip and the nail fold feels boggy. Refer any patient with unexplained nail clubbing for urgent chest X-ray. Jugular venous pressure. Observe the internal jugular vein at 45 degrees with the head turned slightly to the left. Vertical height is measured in relation to the sternal angle. If raised more than 4 centimeters, it causes. If raised, it is raised if it is more than 4 centimeters. Causes of increased JVP. First is fluid overload, right heart failure and congestive cardiac failure, SVC obstruction, non-pulsatile raised JVP, tricuspid or pulmonary valve disease, pulmonary hypertension, arrhythmias, atrial fibrillation, atrial flutter, complete heart block, increased intrathoracic pressure, example, pneumothorax, pulmonary embolism or emphysema. So most of the raised JVP causes are related to the right heart side functions and the pulmonary functions. So Kussmaul sign. The JVP usually drops on inspiration along with intrathoracic pressure. The reverse pattern is called Kussmaul sign, caused by raised intrathoracic pressure and constrictive pericarditis. Causes of Kussmaul sinus: raised intrathoracic pressure or constrictive pericarditis. Signs of infective endocarditis. Infective. Fever. So infective endocarditis sign, infective, is fever, weight loss, clubbing, splenomegaly, anemia. Cardiac signs, murmurs, particularly new onset murmurs plus heart failure. Embolic signs, neurologic deficit due to stroke. Vasculitic signs, microscopic hematuria, splitter hemorrhages under your nails, conjunctival hemorrhages, rot spots, retinal vasculitis, osseous nodes, painful lesions on the finger pulps, Janeway lesions are palmar macules. So osseous nodes are at the nodes, painful lesions on the finger pulps. So these are at the corners of your fingers. But Janeway lesions, these are palmar macules. These are seen in the palm. Signs of hypercholesterolemia. Corneal arcus, a whitish opaque line surrounding the margin of the cornea, separated from it by an area of clear cornea. Rarely congenital, more commonly occurs bilaterally in patients more than 50 years of age, is called arcus senilis, sometimes associated with increased blood lipids, particularly in familial hypercholesterolemias. Check the lipids. If lipids are normal, no treatment is needed. Xanthomata. Localized collections of lipid-laden cells appear as yellowish color lumps, often caused by increased lipids, commonly seen in the eyelids, xanthelasma, on the skin or in the tendons, appear as mobile nodules in the tendons. Examining the heart. Apex beat. Normal position. Examining the heart, apex beat. Normal position of the apex beat is fifth intercostal space in the mid-clavicular line. Moved sideways or inferiorly if the heart is enlarged, example in congestive cardiac failure, or displaced, example in pneumothorax. May not be palpable if the patient is obese. He has hyper-expanded lungs, example COPD, or a pericardial effusion. In infants and children, apex beat is superior and more lateral. Parasternal heave. Detect by placing the heel of the hand over the left parasternal region. If present, the heel of the hand is lifted off the chest wall with each heartbeat. Causes of parasternal heave. Usually, right ventricular enlargement causes parasternal heave, rarely with left ventricular and left atrial enlargement. Heart sounds. Table 9.2. Low or medium frequency sounds, example, third or fourth heart sounds, are more easily heard with the bell applied lightly to the skin. High frequency sounds, like the first and second heart sounds and opening snaps, are more easily heard with the diaphragm. Heart murmurs, due to abnormalities of flow within the heart and great vessels. Very common, often incidental findings, described by location of the murmur, where it is heard the loudest. Quality, blowing or harsh. Intensity, graded 6 out of 6. 1. Virtually undetectable. 6. Heard by an observer without a stethoscope. Grades 4 to 6 are usually palpable, called thrills. Timing, systolic and diastolic murmurs. Radiation, does the murmur spread elsewhere, like into the axilla or to the carotids? Red flag symptoms in cardiovascular disease. These are cyanosis. Red flag symptoms in cardiovascular diseases: cyanosis, lethargy or tiredness, weight loss or failure to thrive, breathlessness, and collapse. Always refer for an echo. Differential diagnosis. Differential diagnosis of heart murmurs. So, back to MBBS basics. Ejection systolic murmur. Increase to reach a peak midway between the heart sounds. Flow murmurs. Example, children, pregnancy, fever, during and after exercise. Aortic stenosis or sclerosis. Pulmonary stenosis. HOCM. All of these produce a ejection systolic murmur. A pansystolic murmur. It is heard throughout the systole. So, uniform intensity in between the second heart sounds merges with the second heart sound. So, second heart sound is caused by closure of the aortic and pulmonary valves. Mitral valve regurgitation or prolapse. Tricuspid regurgitation. BST, AST. So, it's a pansystolic murmur during the entire systole, wherein the left ventricle and right ventricle are pushing blood through the aorta and the pulmonary valves. There are side doors where the mitral valve and the tricuspid valve is regurgitating throughout the systole. So you have a pansystolic murmur in MR, TR, BST, and AST. Early diastolic murmur occurs just after the second heart sound, that is a high-pitched and easily missed because of aortic regurgitation. So just now the aortic valves have closed, the pulmonary valves have closed, and then diastole is starting, and then the pressures drop in the ventricles, and suddenly the aortic wall and pulmonary wall leak. So aortic regurgitation, early diastolic murmur, pulmonary regurgitation, early diastolic murmur, and tricuspid stenosis. Mid-diastolic murmur. Midway in between the second heart sound and of the first beat and the first of the next. Rumbling and low pitch. MDM. So MDM, we remember since our MBBS days, is mitral stenosis. And aortic regurgitation, there is a particular type of murmur called Austin Flint murmur during aortic regurgitation. Let's check what is Austin Flint murmur. Yeah, it's already available at page 2 for 51. We'll read in detail over there. Heart sounds, abnormalities and their causes. First heart sound, heard loudest at the apex, caused by closing of the mitral and tricuspid valves. So first heart sound is soft in mitral regurgitation, low BP, rheumatic carditis, severe heart failure, and left bundle branch block. Loud in atrial fibrillation, tachycardia, atrial premature beats, mitral stenosis. Variable intensity, varying during duration of diastole and complete AV block. Split first heart sound. RBBB, paced beat from the left ventricle, left ventricular ectopics, ASD, Epstein's anomaly, tricuspid stenosis. Second heart sound is caused by closure of the aortic and pulmonary valves. A2 and P2 split on inspiration is normal, so that P2 is heard after A2. Soft. The second heart sound is soft. A2 is soft when calcification of the aortic valve, dilatation of the aortic root. P2 is soft in pulmonary stenosis. Since the pulmonary valves are very close to each other in P2 in pulmonary stenosis, so it is soft. Loud. A2 is loud in increased BP and thin patients. P2 is loud in pulmonary hypertension when there's increased pressure through the pulmonary valves and they open very widely while pushing the blood and then they close with a snap. So that's loud. And ASD, wide splitting, may be the result of early A2 or a delayed P2. Early A2, mitral regurgitation and VSD. And delayed P2, right bundle branch block, there's a pulmonary stenosis, ASD, right ventricular failure. Reverse splitting, A2 is delayed, P2 occurs before A2. So the split between the sounds decrease on inspiration. Delayed A2, left bundle branch block, systolic hypertension, HOCM, severe aortic stenosis, PDA, left heart failure. Single. There's only a single second heart sound. Either there's a calcification of the aortic valve, there's pulmonary stenosis, Fallot tetralogy, Epstein's anomaly, pericardial effusion, large VSD, obesity, emphysema. Clicks and snaps. Early systolic click is caused by opening of the aortic and pulmonary valves, like in aortic stenosis, bicuspid valve, pulmonary stenosis, pulmonary hypertension. Mid and late systolic clicks is seen in mitral valve prolapse. Diastolic, caused by opening of the mitral and tricuspid valves. Diastolic, silent in a healthy heart. Mitral clicks, mitral stenosis, rapid mitral flow, PDA, VSD, severe mitral regurgitation. Tricuspid, rheumatic stenosis or ASD. Third heart sound, heard in diastole after the second heart sound. So, pathological sounds are third heart sound and fourth heart sound. S1 and S2 are normal, S3 and S4 are pathological. Most important cause of a third heart sound, S3, is if it is heard from the right ventricle, the causes are loudest at the left lower sternal edge, never normal, causes are right heart failure, tricuspid regurgitation, ASD and constrictive pericarditis. Left ventricular, loudest at the apex when inclined to the left, can be normal in children and pregnancy. Other causes are left ventricular failure, mitral regurgitation or anterior MI. So, a third heart sound is majorly caused by either a right or a left heart failure or a tricuspid or a mitral regurgitation or an MI, constrictive pericarditis. However, it can also be normal in children and in pregnancy. A fourth heart sound heard in late diastole Maximum at the apex or lower left sternal edge is never normal. Causes are there is left ventricular hypertrophy or right ventricular hypertrophy or fibrosis and HOCM. So these are the two main reasons we can remember grossly. Third heart sound is because of heart failure. Fourth heart sound is heard in hypertrophy of the ventricles and HOCM. Examination of the arterial system. The main conditions affecting the abdominal and peripheral arteries are aneurysms, atherosclerosis resulting in ischemia of the legs and intermittent claudication, atrophic changes or rest pain, embolization resulting in acute ischemia of the limbs. General scheme for arterial examination. Look at the limbs. Are there any signs of ischemia? Are the extremities warm or cold? What color are they? Examine the abdomen. Looking for a pulsatile mass suggesting abdominal aortic aneurysm. Auscultation may reveal a bruit. Check for the peripheral pulses. Tenderness on palpation of abdominal aortic aneurysm suggests need for urgent operative repair. If there is tenderness on palpation, it suggests the need for urgent operative repair. Blood pressure. We'll see in page number 216. Carotid pulse. Carotid pulse. Ask the patient to lie supine with the head or neck at 45 degrees to the horizontal. When assessing the carotid pulse, consider the rate. Either there is tachycardia more than 100, bradycardia less than 60 beats per minute, rhythm, regular, irregularly regular, atrial fibrillation, irregular AF, regularly irregular, second degree heart block. Character and volume. Always assess with the central pulse, example carotid or femoral pulse. Small volume, shock or pericardial tamponade. Aortic stenosis has a slow rising pulse. Large volume, hyperdynamic circulation like pregnancy, aortic incompetence, water hammer or collapsing pulse in aortic incompetence or regurgitation. PDA. PDA there is again hyperdynamic circulation. So pulsus paradoxicus. The pulse weakens in inspiration by more than 10 millimeters of Hg. Asthma, cardiac tamponade, pericarditis. The causes of pulsus paradoxicus is asthma, cardiac tamponade and pericarditis. Carotid bruit. Many signify stenosis more than 30%, often near the origin of the internal carotid artery. Heard best behind the angle of the jaw. Usual cause is atheroma. Peripheral pulses. Location of the peripheral pulse to be examined is table 9.3. Examination. Check whether each pulse is present. If present, check the rate of the pulse, the rhythm of the pulse, the amplitude, and compare the pulses in two legs or two arms. Check for radiofemoral delay. Palpate the radial and the femoral pulses simultaneously. A delay suggests coarctation of the aorta. So this is table for location of the limbs pulses. Brachial pulse. Location of palpation 2 centimeters medial to the central point of the anterior cubital fossa over the elbow skin crease. Radial 1 centimeter on the radial lateral side of the flexor carpi radialis tendon at the wrist. Femoral pulse below the inguinal ligament 1/3 of the way from the pubic tubercle. 1/3 of the way from the pubic tubercle. Popliteal pulse. With the knee flexed at right angles, palpate deep in the midline. Posterior tibial pulse. 1 centimeter behind the medial malleolus. Dorsalis pedis pulse. Variable on the dorsum of the foot just lateral to the tendons to the big toe. Many people have only one foot pulse. This is a very important table. I will share it in the group. Check for the bruits over the femoral or carotid pulses. These indicate disturbed blood flow. So any femoral bruit or carotid bruit result indicates disturbed blood flow, usually secondary to narrowing due to atherosclerosis. Character and waveform of a pulse should only be assessed during femoral and carotid pulse. Signs of ischemia. Acute ischemia. Acutely pale, cold, pulseless limb. Refer immediately. Keep the limb cool in the interim. Chronic ischemic changes. Atrophic skin. Pallor, cool to touch, hairless, shiny. On lowering, the leg turns dusky blue-red color. On elevation, pallor and venous guttering is seen. Ulceration. Check under the heel and between the toes for ulceration. Swelling. Suggests that the patient is sleeping in a chair to avoid rest pain or rarely pain from deep infection. Absent foot pulses. If pulses are present, consider alternative diagnosis. So ankle brachial pressure index less than 9.95. This is a very important parameter for checking any atherosclerotic changes in the limbs. Arterial insufficiency, ankle and brachial pressure index less than 0.95. How do you check the ABPI? This is very important. So, checking the ankle brachial pressure index, check the BP on one arm. The systolic measurement is brachial pressure, B. Then inflate the BP cuff around the lower calf just above the ankle. Using a Doppler ultrasound probe, record the maximum cuff pressure at which the probe can still record a pulse, that is the ankle pressure. So calculate the ABPI by dividing the ankle pressure by the brachial pressure. So ABPI is equal to ankle pressure divided by brachial pressure. Interpretation of ABPI results. ABPI less than 0.8 is ischemia. ABPI less than 0.5 is critical ischemia. Arterial calcification, example due to diabetes mellitus, can result in falsely elevated ankle pressure readings. So, it is the ankle pressure over the brachial pressure, and we require a reading anything in between 0.9 to 1.2 is normal. Less than 0.95 is suggestive of chronic ischemia, and less than 0.8 is ischemia, less than 0.5 is critical ischemia. So, as such, the brachial pressure is normally higher than ankle pressure. Cardiac investigations, electrocardiogram. Graphic recording of electrical potentials generated by the heart. Most surgeries now have an ECG machine and that interpret themselves and print out the findings. Analysis is easier, but it's still important to be able to understand the significant abnormalities and check computer analysis in the clinical context. Interpreting ECGs. Many mistakes in ECG interpretation and errors of omission are errors of omission, so a systematic approach is best. Check standardization, calibration, and technical features, including lead placement and artifacts. Heart rate. Usual speed is 25 millimeters per second. Each big square represents 0.2 seconds. Each small square represents 0.04 seconds. Rate is 300 divided by RR interval in large squares. So this is how you calculate heart rate in an ECG. You divide the 300 divided by RR interval, either 2 squares or 3 squares. You divide it the 300 by that, and then you will find the heart rate. Rhythm. regular or irregular. You have to check the two RR intervals, three RR intervals, and then see whether they are regular or irregular, either same or not. PR interval, normal if less than 0.2 seconds. QRS interval, abnormal if it's more than 0.12 seconds. So if it is more than 0.12 seconds or more than 3 small squares, the QRS complex, more than 3 small squares wide, that means it is a wide QRS complex. QT interval varies with rate. At 60 bpm, normal is 0.35 to 0.43 seconds. P waves, either they are present or absent, and the shape. QRS voltages, height of the complexes. So we have a table to check that out. Meanwhile, mean QRS electrical axis. How do you determine the electrical axis of an ECG, whether there is any axis deviation or not? This is an important point. So, mean QRS axis is sum of all the ventricular forces during ventricular depolarization. Normal axis is between minus 30 to plus 120. If more, that is, if it is more negative than minus 30, it is a left axis deviation. If it is more positive, then it is a right axis deviation. Rule of thumb 1. If majority of the QRS complexes is above the baseline, that is positive, in leads 1 and lead 2, the axis is normal. Rule of thumb 2. The axis lies at 90 degrees to the QRS complex where the height above the baseline is equal to the height below the baseline.